in the process of genetic counseling and testing and have actually reported fairly low rates of participation. This morning, Dr. Jane Churpek will summarize the findings of a comprehensive genetic profiling of African American women diagnosed with breast cancer right here in Chicago. Dr. Churpek.
Thank you very much, Dr. Seidman. As he mentioned, my name is Jane Churpek, and I'm a hematologist-oncologist at the University of Chicago. And today I'm going to tell you about our work to characterize the prevalence of inherited mutations in breast cancer susceptibility genes among African American women with breast cancer. This question is important because we know that breast cancer survival is overall worse for African American women than for white women, and this disparities gap continues to widen. For those of us here in Chicago, it's particularly relevant because we have one of the worst disparities in the country. It's also important because we know that the incidence of advanced breast cancer is increasing among young women, especially young African American women. And these women would not yet have reached the age of breast cancer screening and thus would not have had the opportunity to have their breast cancers detected early. So it's even more important that we better understand who is at risk. One potential contributor to these disparities may be differences in tumor biology. We know that African American women are disproportionately affected by early onset breast cancer, meaning occurring at an early age, and also develop more aggressive forms of breast cancer called triple negative breast cancer. We also know that inherited mutations in breast cancer susceptibility genes increase a woman's risk for these specific types of breast cancer, early onset and triple negative breast cancer. So one potential theory is that maybe this population has more mutations in these genes, and that could account for some of these differences. But right now, we don't know the prevalence of mutations in these genes, even in the general population, and we chose to focus on African American women. So our aim was to estimate the prevalence of inherited, clearly damaging mutations in all 18 known breast cancer susceptibility genes, including BRCA1 and BRCA2, among African American women with breast cancer. And we also aimed to gain experience with panel-based testing in this population. For this study, our approach was using BRCA, which is an assay that uses new tools called targeted genomic capture and next-generation sequencing to examine multiple genes at once, and it identifies multiple types of genetic changes in those genes all at the same time. This is very different than current clinical testing because current testing requires us to do BRCA1 and BRCA2 first, which is actually a two-step test. Then, in appropriate situations, we can consider doing a panel, but right now, BRCA1 and BRCA2 cannot be included in those panels because of Myriad Genetics' patent on those genes. Therefore, for many patients, genetic testing can be a multi-step, multi-expense process. Our study population included 249 African American women with breast cancer that we ascertained from our cancer risk clinics and breast cancer clinics at the University of Chicago. Importantly, these women were, on average, 43 years when they were diagnosed, and thus are younger than the average population of breast cancer patients, and at baseline had a higher chance of having an inherited mutation than the general population. With this technique, we found that 22% of the women that we looked at inherited a clearly damaging mutation in one of these genes. And as you can see from the pie chart, the majority of these did occur in BRCA1 and BRCA2, 79%. However, we also found 21% of mutations in other genes with defined cancer risks, including ATM, CHEK2, PALB2, and PTEN. Also of note, almost all of the mutations that we identified were different, meaning that each woman inherited a different mutation that was not seen in the other women. And this is important because for some populations, we can use tests which look at only a few sites in a few genes, and we can identify the majority of mutations. But that technique will not work for this population with such great genetic diversity. We also looked at how these mutations were distributed by personal and tumor characteristics. And as expected, those with a family history of breast or ovarian cancer, those with triple-negative breast cancer, and those who were young at diagnosis had near 30% of women in those categories carrying mutations in our subset. Also, very importantly, even among those who did not have a family history of breast or ovarian cancer, over 10% still carried mutations, again reminding us that family history is not the only criteria that we should think of or that will predict well who has these mutations. So in conclusion, the proportion of African American women with breast cancer with inherited mutations detected by BRCA in our series is high. This work highlights the critical role of improving awareness and access to genetic testing and counseling services for all women, especially African American women, who have unfortunately not utilized this service well in the past for a number of reasons. It also shows that these new techniques, which allow us to comprehensively screen multiple genes at once, including BRCA1 and BRCA2, all in a single test in a single visit, really will allow cost-effective and efficient genetic testing, which is currently not clinically possible. And these tools will allow us to better identify who's at risk before they develop cancer, so we can begin to focus on prevention and eventually impact public health. Thank you.